All right, so I have the pleasure of introducing Dr. Meena Khan today. Dr. Khan received her medical degree from Ohio State University, where she also completed her neurology medicine residency and sleep medicine fellowship. She is currently an associate professor in the Department of Internal Medicine and Neurology at the Ohio State University and is also the program director of sleep medicine fellowship there. Her interest is primarily focused on management of the sleep medicine upper airway stimulator therapy program and sleep disordered breathing, also management of non-invasive ventilation in patients with neuromuscular disease. She has lectured in various courses in sleep disorders nationally and is very involved in educational activities. She's also received an Excellence in Teaching award and has authored many publications. Dr. Khan also has held leadership position in many national societies. Thank you so much for being with us, Dr. Khan. And without any further delay, I would like to hand it over to you to share your expertise on phrenic nerve stimulation for central sleep apnea.
All right, thank you. Thank you very much for having me this afternoon. I'm happy to be here and talk about this therapy with you guys. All right, let me just, okay. So I'm going to talk to you about transvenous phrenic nerve stimulation for central sleep apnea this afternoon. This is the slide about the CME disclosures and accreditation, and then I think they said they're going to put this in the chat as well for you guys. I don't have any conflicts of interest. If I do mention brand names with regards to phrenic nerve stimulation, it's just because there's only one FDA-approved device remedy on the market right now, but I don't have any affiliations with the company. So hopefully by the end of this presentation, we can describe the indications for phrenic nerve stimulation for central sleep apnea, understand the mechanism of phrenic nerve stimulation to treat sleep disordered breathing, and discuss the literature regarding improvements of sleep disordered breathing with phrenic nerve stimulation therapy, and then possible side effects. So as I'm sure several, we all know, central sleep apnea is the result of an interruption of the neural output from the respiratory control centers into the brain to the respiratory muscle activity, the respiratory muscles. There can be several etiologies for central sleep apnea. Congestive heart failure is probably one of the most common things. 40% of patients with congestive heart failure, particularly those who have a reduced ejection fraction, have central sleep apnea. There can be central sleep apnea induced by opiate use. Those who have brain abnormalities such as Chiari malformations, and then there are some that are idiopathic. When we see central apnea on a sleep study, this is typically something that we might see. So this is just a snapshot. This up here is the snore channel, the green signal, the black is the flow, the blue are the effort, and then here's the oxygen saturation. And so we can see there's flow and then cessation of flow without effort, and then resumption of flow. And there is some crescendo, decrescendo here as well that can be indicative of Cheyne-Stokes, which can be seen in those with heart failure with reduced ejection fraction. And then we also see the cardioballismic artifact here, where because the effort belts are sitting on the chest, is picking up the heart rate, and you can see those oscillations here, and those are pretty indicative of central apnea events as well. And then this patient doesn't really have any snoring. And those who have heart failure, we may see this Cheyne-Stokes pattern where you have the crescendo, decrescendo apnea, crescendo, decrescendo apnea. The cycle length from the beginning of the apnea to the end of the decrescendo phase should be at least 40 seconds. And then, in order to say someone has central sleep apnea with Cheyne-Stokes, we have to have both of these. So at least 3 consecutive central apneas or hypopneas separated by this crescendo, decrescendo pattern with a cycle length of at least 40 seconds. And then at least 5 central apneas or hypopneas per hour of sleep associated with this crescendo, decrescendo breathing with a minimum recording time of at least 2 hours. And then you could say this patient has central apnea with Cheyne-Stokes respiration. When you look at the presence of sleep disorder breathing, particularly with heart failure patients, there is literature that supports that it's associated with poorer outcomes in those patients who have heart failure. So here, if you look at on the left, this is the percentage on the y-axis, on the x is the number of readmissions in 6 months. And the blue is having central sleep apnea, the maroon is not having sleep disorder breathing. And over time, when you look as the number of readmissions goes up, the prevalence of those that have central sleep apnea is a bit higher, indicating there may be some association. And then on this graphic here, there's patient survival on the Y and months post-discharge here on the X. And black is not having any sleep disordered breathing, blue is having obstructive sleep apnea, red is having central. And as we can see over time, those with either central or obstructive sleep apnea, their survival curve is coming down, and no sleep disorder breathing as well is decreasing, but there is a significant difference between the two, whereas those with obstructive or central sleep apnea, their rate of survival is declining faster. And then there are studies similar to this that show that treating sleep disorder breathing may improve outcomes. So this is, again, patient survival here on the Y, and then months post-discharge on the X. These dotted lines are obstructive sleep apnea and central sleep apnea untreated. The solid green is OSA treated, the red is central sleep apnea treated, and the black is not having any sleep disordered breathing. And as we can see over time, there's a separation between the two, whereas those who have untreated obstructive and central sleep apnea, their survival is going down significantly over time after discharge. And those that are treated, their survival is similar, in line with those who don't have any sleep disorder breathing. And there is a significant difference between these groups here. So, treating sleep disorder breathing we feel is important for cardiac health, especially in patients with congestive heart failure. And so there's options such as optimizing heart function. If heart function is optimized, essential apnea in particular can improve. PAP therapy can be options. And then the phrenic nerve stimulator, which is what I'll talk about today. So in terms of phrenic nerve stimulation, basically, it's an implantable device that stabilizes breathing by stimulating the phrenic nerve to activate the diaphragm muscle. So this is done through interventional cardiology in the catheterization lab. This is the generator here that's implanted, and then the sense lead is within the generator. The stimulation lead is snaked through one of the veins, typically the brachiocephalic or the pericardiophrenic vein on the left. You have to have a vein that's next to the phrenic nerve because it stimulates the phrenic nerve through the vein, and it stimulates the hemidiaphragm. And when it stimulates the hemidiaphragm, it actually engages both. And we'll go into the details of how it's set, but basically we set a target rate that we want the patient to be breathing at. And if they're not at that rate, the phrenic nerve stimulator will stimulate the phrenic nerve to engage the diaphragm so they meet that target rate. And this is just an X-ray of a patient that has an implanted device. So I'm not sure if you're all aware of upper airway stimulation or Inspire, which is used for obstructive sleep apnea. With that device, the patient turns it on with a remote at night and can go up and down on levels. This device is a little bit different. It has certain parameters of when it's going to turn on at night and turn off in the morning. And it self-titrates the amplitude or the strength of stimulation. So for it to turn on at night, there have to be three things in place. There's a scheduled time that the patient says they'll fall asleep by, that it has to be that time or later. They have to be in a certain reclined position that is set into the programmer by us. And then they have to not be moving. And then when those three things are in place, the device turns on. And then it will turn off in the morning at a time that's established that they wake up. It can be paused by the patient in the middle of the night by sitting up. So when the patient sits up, there's an automatic pause. The range we can program for that is 1 to 30 minutes, but typically we do around 10 to 15 minutes. After that time has passed, the device assesses if all three criteria are met. So the time is after the time they should fall asleep, they're in the reclined position, they're not moving. And if all those are met, it will restart therapy. If the patient moves side to side, we can program a pause time for that. Typically we do around 2 minutes. Again, after that time has passed, it'll reassess all three criteria. And then if they're all three met, it will restart therapy. This is an image of how the therapy works. So here we see central apnea going on here with some Cheyne-Stokes respiration pattern, and therapy is off. There's a range. The strength of stimulation for this device is measured in milliamps. So you'll have a min and a max range. Let's just say in theory, it's 3.5 to 4.5, let's just say. once the time has set and the therapy turns on, it analyzes the breathing and sees if the patient is at the target breath rate that's set into the device. And if it's not, it will increase the milliamplitude or the strength of stimulation until it captures the breath rate that's been programmed into the device. And then once it reaches that target milliamplitude, we call that capture, that they've captured their rate. And then you can see here where the therapy is turned off and the central apnea has come back. So the FDA indication for phrenic stimulation is moderate to severe central sleep apnea. So it's quite broad. There are not exclusions. So the patient does not have to try and fail PAP therapy. They don't have to have a minimum number of obstructive apneas. If they have moderate to severe central apnea, they can be implanted. Although you do have to have some caution. If they do have more than 20% obstruction, they likely will have residual sleep apnea, obstructive sleep apnea. That's going to require some sort of treatment. And in the pivotal trial, which we'll go over later in this presentation, that led to the FDA approval, they did exclude patients who had more than 20% obstruction. So you do have to keep that in mind if you're going to recommend patients for therapy that have more than 20% obstruction on their sleep study. And this device is MRI compatible. So there is no exclusion for MRI for this therapy. So now I'm just going to go over kind of overall what the patient care pathway looks like. So once the patient is implanted, there's about a month or a 4-week time period between implant and when the patient is what we call activated, where we start programming the metrics into the device for the patient to start therapy. So during this 1 month time, the device can actually acquire data from the patient on their sleeping position and their activity. So when they tend to be active versus not active. And that can be used at the activation visit, as well as talking to the patient, obviously, when it looks like they fall asleep and they wake up. So we can start programming those things into the device. And then we'll go over kind of these steps in more detail in the upcoming slides, but just in general, in that activation appointment, we're going to set the time therapy turns on and turns off. We're going to set the pitch, which is the level the patient has to be below for therapy to kick on, and then the amplitude range, or the milliamp, or the strength of stimulation range, which is measured in milliamps. And this can be anywhere from 0.1 to 10 milliamps, and there's a range, there's a min and a max. And again, I'll go over that in more detail in the upcoming slides. The patient then will go home and start therapy, and the device will self-titrate the amplitude weekly for 6 weeks. So basically every week it increases that min and max range by a certain percentage, with the goal to be 20% higher over that 6-week period. Then the patient will have an appointment 6 weeks after that activation visit, where we look at the program or look at data, see if we're getting capture. Again, I'll show you that information in more detail in the upcoming slides. And then do we need to adjust that amplitude range, that milliamplitude range? And then usually this happens for a few visits. And then once it looks like we've really have captured the patient's breathing and they're tolerating therapy and feeling better, we'll do a sleep study to see how well they're responding to therapy. Ideally, this is done in the lab because we're looking at central apneas. But there are patients in our institution in particular, which I'm sure is true of several institutions, you have patients coming from 1 to 2 hours away. They don't really want to come to the lab and that type of thing. So we have done home studies on some patients who really are not wanting to come into the lab, but the in-lab is the preferred way to see how they're responding to therapy. Once it looks like their settings have been optimized, we see them every 6 to 9 months to monitor their response to therapy and also to monitor the battery life. The hypoglossal nerve stimulator or the Inspire, typically you change that battery out every 10 years or so. This one, it depends on how much energy they're using. If they're on the higher milliamplitude range, they may have to have their battery changed out more often than if they're on the lower. And so the battery life is something that we monitor as well. And when it starts to go down, we'll schedule them for a battery change. So this is some data that you can get from the device between when it's implanted to when we activate it, as well as while you're following them on treatment. So this would be their pitch. So basically, at what time does it seem that they're reclined versus inclined, and kind of see what's the average that you're seeing, and then match it up with what the patient says they fall asleep and wake up, and also their activity level. when do they seem to be least active versus most active? Again, lining that up with the data about their pitch and what they say they go to sleep and wake up, and they can use that as a way to designate when you're going to have the therapy come on and turn off. So at the activation appointment, basically the patient, this is the telemetry cord here that you put on top of the generator, the IPG, and then this is the programmer that's used so that we can read things off the device and implant and program things into the device. The goal breath rate typically that we'll start out with is the breath rate while they're awake -2 as the goal breath rate. So we program that into the device. We program the times therapy turns on and off. So again, the time it turns on is when the patient says they're asleep, and then you can also set a delay. So if they say, I go to bed at 11 and it takes me 15 minutes to fall asleep, you can set a delay of 15 to 30 minutes, and it will pause for that amount of time after 11 before it's going to turn on. You want to program the time the therapy should turn off in the morning. You want to program the time that it's going to pause if the patient sits up. So again, that can be anywhere from 1 to 30 minutes, with the default being 10 to 15. Again, after this time has passed, it will reassess for the 3 parameters to restart therapy, which is time after falling asleep, pitch, not moving, and then restart therapy. And then you can also put in the time where therapy pauses if they're moving side to side. Typically, we make this shorter, around 2 minutes, because usually they're just turning over. They're not really fully waking up. And so you can make this shorter before it reassesses for all 3 things and restarts therapy. And then we program the amplitude range in milliamps. So again, this is the minimum and the maximum. And we do it in all 4 quadrants. So supine, right, left, and prone, because they may tolerate different amplitudes in different sleeping positions, and also their breathing might be different in different sleeping positions. So the minimum amplitude that's programmed is what's comfortable for the patient to tolerate while they're awake. And the max is what's uncomfortable, a little bit what below what's uncomfortable. And then that's the range. And again, when they turn the device on, the device is reading their breathing. If they're not at that goal rate, it will increase that milliamplitude within that range until it captures the goal rate. So during this 6-week period between visits, it's going to analyze the breathing every minute, and again, increase the milliamplitude in that range that's set until breath rate is captured or met. And then the device increases that min and max range weekly to a goal of 20% after 6 weeks. And then at 6 weeks, they're seeing programmer data is evaluated, and we see if that milliamplitude range needs to be changed, how the patient is doing, are they tolerating it, and then reset it, and then have them go home for another 6 weeks, and then come back for another appointment. If we're having difficulty titrating them, or not really look like we're not getting capture, the patient may not be tolerating the therapy very well, you can titrate patients in the lab. Typically, we have a representative from the company come and do that if we're not really being successful with this outpatient programming. So some of the things we're going to look at in the follow-up appointment, again, we're going to see here their pitch. Are they going below pitch? And what times is that occurring? Their activity trends, is this matching up with the times therapy is on and off? And then we can look at therapy duration. How long are they really using therapy night to night? If it's on the low end, if they're only using it a few hours, is there a reason? Are they having to pause therapy? Do you see that they're breaking pitch a lot, where they're sitting up a lot? Is that because of therapy? So these are all things that you can, if the patient doesn't come out and tell you, you may be able to gauge that there's something going on looking at this data. And then the capture index. So are we capturing their breath rate? So if they're reading in the red, which is low or medium, then that wouldn't be good capture. If they're reading in the high end, which is the green, then they're capturing well. So this patient, and you can see it in all 4 quadrants, so right, left, supine, and prone. You can see it night by night. You can also see it as an average over 3 weeks. And so you can say, for example, this patient looks like they're capturing around 0.9. And let's just say, they're on 0.4 to 2, just to say. But they're capturing around 0.9. So then maybe you're going to adjust that range and have it start. And they say they're tolerating therapy, it's not bothering them. Maybe you'll adjust the range. So the minimum is now 0.7 as opposed to 0.2. And that way they're starting a little higher and then can kind of make sure that they're more in that capture range most of the time and not starting out too low. So again, after a few visits, when it looks like we've really obtained capture from the programming data, we'll do a sleep study to objectively quantify how they're responding to therapy. An in-lab study is ideal, but in our institution, we have done home studies in patients who will not do an in-lab or prefer the home study. If we see continued central apneas, then we'll further titrate the settings and retest. If there's residual significant obstructive apnea, which we have seen in a decent number of patients, then we need to discuss that with the patients. How are we going to manage that and that type of thing. Once they're stable on therapy, we see them every 6 to 9 months, again, to monitor how they're doing, their usage, and then also the battery life of the device. Once they're kind of in this maintenance follow-up stage, meaning we feel like they're on optimal settings, they look like they're doing well, we're seeing them regularly just as follow-up maintenance visits. These are the things that we look at: battery status, their therapy duration, their efficacy and capture, and then you can look at some waveforms to get an idea if they're having significant breathing events or not. So this is what their battery status can look like. So green means they're good. They're having plenty of battery life. When it starts hitting into the yellow, we're like, okay, we probably need to see them every few months, so every 2 to 3 months, to keep an eye on this. And when it starts approaching the lower end of orange to red, they need to be scheduled for a battery change out. We can look at therapy duration. So how much therapy are they getting per night, and are they breaking pitch? So the gray here is how much time they're getting therapy. So here, this is pretty good. I mean, this is like 7.5 a lot of the time. And then you can see, are they breaking pitch? So, getting up once or twice a night is fine. If it's getting 4, 5, 6, 7 times, we probably need to ask them, is it because of therapy? Is there something else going on we can help you with? If their duration of use is down here, 3 or 4 hours, is there a reason for that? Is it related to therapy? Is there something going on that we can help you with? So this can be helpful in terms of how much therapy they're getting and if there could be problems with tolerating it. And again, we look at capture. You can look at them individually per night. You can also look on average, and you can see, are they getting the high capture, times of night where their capture is high. And then also you can see, what's the milli amplitude that they tend to be capturing on, and use that as a gauge of whether or not you need to adjust your range or not. You can also get waveforms that you can look at, and they're not perfect, but they can give you an idea. So this would be someone who looks like they have pretty good synchronized breathing and capture. You can look at waveforms at different milli amplitudes. You can look at them at different positions, and then you can look at different times and kind of get an idea of what things look like. This would be an example of someone that maybe they're having some central apneas. You see this kind of, these could be maybe cardiac oscillations. And so if you're seeing a lot of these, and then you can also see, are they having it on the right? Are they having it on the left? Are they having it in the supine position? And then you could just adjust the range for those quadrants. So for example, if they look great in the supine position and the left position, but on the right, they have a lot of central apneas, you could just adjust that milliamp range for the right side. You don't have to adjust it for all the quadrants. This may be a hypopnea. And again, if you have someone who has residual obstructive apnea, we can't tell if this is central obstructive. We can just see this waveform looks like there's potential hypopnea. And then you'd have to put that together with the clinical picture. So we have a few patients where the studies have shown their central apnea is well controlled, but they have residual obstruction. And it could be that these hypopneas are obstructive. And so you wouldn't necessarily be adjusting the phrenic nerve stimulator for these. Rather, we should be talking to the patient about treatment for their obstructive apnea. So this is the data from the pivotal trial. So this is the trial that led to FDA approval of the device. This was a multi-center trial. They had 151 patients that they enrolled in this trial and randomized to treatment versus control. And at the end of 6 months, they had 58 here in the, let's see here. I'm sorry, no. We had 73 assigned to treatment and 78 that were assigned to controls. So to be included in the study, you had to be medically stable for 30 days prior to entering the study. They had to have an apnea-hypopnea index of at least 20. They had to have more than 50% of the apneas being central and at least 30 central apnea events over the entire study. The obstructive apnea index had to be less than or equal to 20%. And hypopneas in the study were not designated as obstructive or central. And of these 151 patients, 96 of them were heart failure. They excluded patients that had opiate-induced central apnea. So we don't have data on that patient population. And so what they did was they looked at the data at 6 months. And this is probably hard to read there because the print is so small. But they had, with the central apneas, they had a significant improvement. So at baseline, if you look at the treatment group, the baseline was around, first the central apnea index was around 31.7, and then it went down to around 6. Whereas the control group, it was on 26.2, and it went to about 23.3. So really no change. And then if you look at the apnea-hypopnea index overall, for the treatment group, the baseline was around 49. And at 6 months, it was down to about 25.9 or 26. And then for the control group, it was 43.9. And then it went to around 45. So not a meaningful change in the control group. Other things that were improved, the arousal index was improved, and the oxygen desaturation index was improved. And then the Epworth, which is how they measured sleepiness for this study, the baseline for the treatment group was around 10.7. And at 6 months, it went to 7.1. The control was 9.3 and then went to 9.4. So not a significant difference, but there's a significant difference in the Epworth. In general, I believe an Epworth improvement of 2 points is considered significant. So they had a significant improvement in the Epworth as well. And then this is just a graphic looking at the response. So this is the treatment group, and green is a decrease in the apnea-hypopnea index, and red is an increase. So in the treatment group, significantly more green than red, whereas in the control group, there were some green, but definitely not as many as in the treatment group. And then subjectively seeing how patients felt, the treatment group, the majority of them felt markedly to moderately improved, about 19% mildly improved, and then about 20%, well, I guess 14% was neutral, no change, and 6% was worse. And then in the control group, there was a small percentage here that felt they were improved. The majority of them, 61%, said no change, and about 25% felt they were worse. So subjectively, the treatment group felt better than the control group. In particular, they looked at heart failure patients. So once the 6 month block of the 6 month data was done, they offered the treatment to everyone therapy in the control group, and then followed them out. And so in particular, they had this evaluation of those who had heart failure patients and and that was 96 patients at enrollment. And then at 12 months, about 75 of those completed the visit. And so and 70 of them had PSG data. And so what they found was that the central apnea index at baseline in this group was around 26.2. And then at 12 months, it was down to 3.5. So it was decreased to about 4 at 6 months and down to 3.5 at 12. So basically maintained that reduction up to a year. And the apnea-hypopnea index was 47.1. At 6 months, it went to 25.2 and maintained that, at 1 year. So basically the reduction in central apnea index and in the apnea-hypopnea index was significantly reduced at 6 months and maintained that to 1 year. And then ODI, it had a similar improvement, and arousals also had a significant improvement. And this is just a graphic looking at the central apnea, the mixture of what really responded to the phrenic nerve stimulation. So this like foam green is hypopnea, the gray is mixed apnea, dark blue is obstructive apnea, and the green is central apnea. So at baseline, a significant sleep disorder breathing events. And then at 1 year and out to 5 years, the overall, sleep disorder breathing burden decreased significantly. It was maintained out to 5 years. And that is mainly through the reduction here in the central apneas in the orange. The hypopneas did not change much, and the obstructive apneas didn't change, which we would not expect it to. There have been a few systemic reviews that have been published. This is just one that I found, although a lot of this data is coming from kind of offshoots of the pivotal trial data. The overall conclusion was there was a significant decrease in central apnea index and a mild to marked improvement in quality of life in patients who are implanted with the phrenic nerve stimulator for central sleep apnea. So next, I was just going to go over some cases that we have at OSU of patients implanted with phrenic nerve stimulation. So this first one is a 71-year-old male with severe sleep apnea, diagnosed in 2019. His apnea-hypopnea index was 57.6. He had 1 obstructive apnea, 2 mixed apneas, 121 central apneas, and 81 hypopneas. So his obstructive index, which is the obstructive and mixed apneas that we lumped together, was 0.85. The central apnea index was 34, and his hypopnea index was 22.8. He was implanted in 2020, and he did well after implant. He was subjectively very happy and felt that he was better. He had a home sleep study a year after implant, and it had a respiratory event index of 26.9. He didn't have any mixed or central apneas. Those resolved, but he did have 36 obstructive apneas and 153 hypopneas. So it seemed to be more obstructive events than on his diagnostic study. And this is an example of what it looked like. So these are the hypopneas here, which appear to be obstructive looking. And when you look at the difference between supine and non-supine, there's significantly more in the supine position. He had a respiratory event index of 45.2 when he was supine, and non-supine he was 6.4. He subjectively felt really great. He didn't feel like he had residual sleepiness or problems. He was not interested in addressing using PAP therapy or an oral appliance. So he wanted to try to sleep on his side. Because this was a home study, I said, let's do an in-lab and just get a good idea of, making sure we're getting a clear picture here. So he did have an in-lab study a few months later. He slept completely in the non-supine position, and his apnea-hypopnea index was 4.3. And so this is how he's decided he's just going to sleep on his side and use the phrenic nerve stimulator for the central apneas. This is another case. This is a 55-year-old male who's diagnosed with severe central apnea in 2017. His weight was 188 pounds at that time. His apnea-hypopnea index was 44.4. And he had majority central apneas, and then he had hypopneas that were not distinguished as obstructive or central. He did try BiPAP ST for some time, but he could not tolerate it. And so he was implanted with phrenic nerve stimulation in 2018. We didn't get another sleep study until July of 2020. He had some titration studies in between because he was someone who they were having difficulty adjusting his settings on the outpatient basis. So he did have a couple in-lab titration studies, and then he had an overall in-lab study on his settings that he seemed to be responding well with in 2020. His weight was 214 at that point, so he's been gaining weight. His residual apnea-hypopnea index was 16.7, and he didn't really have many obstructive apneas. He had 1 obstructive apnea, didn't have any central apneas or mixed apneas, and mainly hypopneas. And so it was recommended to further increase his phrenic nerve stimulation settings because some of these hypopneas could have been central. He then ended up having a home study in 2022 with the phrenic nerve stimulator. His weight's now 213, so about the same as 2020. And his respiratory event index was 30, and he had 117 obstructive apneas at that point. He had a few centrals, but not too bad, and then 123 hypopneas. The hypopneas all looked obstructive. And then when you looked at the difference between supine and non-supine, his supine REI was 37.4 and non-supine was 22.8. So a little bit less than the non-supine position, but still significant. So at follow-up, we kind of discussed this with him, that his central apnea looks fairly well controlled, but he is having residual obstructive apnea. We talked about trying PAP therapy or an oral appliance. He is not in favor of doing either one of them. Positional therapy may be a little bit better, but not ideal. And so there is this discussion, should we do dual implant with him? So hypoglossal nerve stimulator for the obstructive apnea. I don't believe there's any published cases, but when you talk to the people at Zoll, there are a few cases of people with dual implant. They say that they're doing well, but I don't have the data about that. And this is the first person I've even thought about it in, because he is reaching kind of the severe end of obstructive sleep apnea and he keeps gaining weight. And so it is something that we haven't really committed to doing it, but just trying to get information if this is something we should consider for him, given that his obstructive index is in the severe range and he's not really willing to use any other treatments. So we're still in discussions about this. We just saw this patient a few weeks ago, so I'm not sure if we're going to go forth with dual implant, but it is something that's kind of being discussed more and more, whether or not we should be considering dual implant for some of these patients. And this third case, this is a 69-year-old male with moderate sleep apnea. He has a history of heart failure, hypertension, and anemia. He has diagnostic study in October of 2020. His weight was 193 at that point. His apnea-hypopnea index is 24.7. He had 112 central apnea. So his central apnea index was 17.4. He didn't have much obstruction, so just 4 obstructive apneas, 1 mixed apnea, and 42 hypopneas. And it was noted that he did have some Cheyne-Stokes respiration with cycle lengths of 43 seconds on this study. He was started on CPAP and had a titration, but the central apneas continued. And he was referred for phrenic nerve stimulation therapy. And I'm not sure, I wasn't part of the program at this time, so this was before I had started with the phrenic nerve stimulation program. So I don't know if he'd tried bi-level and wasn't tolerating it. I'm not really sure, but he ended up going for implant. It was implanted in 2020. And then in 2021, he had a polysomnogram with the phrenic nerve stimulator, and his apnea-hypopnea index was 19.4. And he didn't really have much central apnea. He only had 2 central apneas, but he did have 21 obstructive apneas and 94 hypopneas that were thought to be obstructive. So the residual AHI is really stemming from obstructive events as opposed to central events. So he followed up in a joint clinic that's with sleep medicine and cardiology to manage these patients chronically. And he's using CPAP with his phrenic nerve stimulator, and he felt he was doing fine. He's happy using both. He feels that he's tolerating the CPAP. He didn't have his device with the first visit where I saw him in this combined clinic. He did not have his device for download, but we were looking at the programmer, and as I had pointed out before, we can look at waveforms, and there were waveforms coming up, several waveforms that look like they were hypopneas of some sort. And so the question, the cardiology nurse practitioner who does the phrenic nerve stimulator programming in our institution asked was, should I adjust this programmer for these events? So since we didn't have a download, I said, let's just obtain a download before we do anything. And so he had a download. He has an auto set device, but he was fixed at a pressure of 8. And when we look at his download, I mean, he was using it well, but he had a residual apnea hypopnea index of 22. And when you look down at the breakdown that the machine was giving, it looked like it was mainly obstructive apneas. The central apnea index was low. And he wasn't having much leak. And so I just had said, let's just put him in an auto mode, 8 to 12, and let's just see what happens. And we didn't change his phrenic nerve stimulator settings. And so when he came back, his residual apnea hypopnea index had come down, and he was doing well. And so he's been maintained on CPAP with the phrenic nerve stimulator. So in conclusion, so the phrenic nerve stimulator is FDA approved for moderate to severe central sleep apnea. There are not any exclusions for having obstructive apnea or trying PAP or anything like that. But obviously, when you have a patient, you want to make sure you discuss all the treatment modalities and the data we have for all of them and see, what may be best for the patient. And if you have someone who has more than 20% obstruction, they're probably going to have residual obstructive apnea that needs to be dealt with. And so they should be prepared for that. Also, there are cases where the obstructive index is worse after implant versus before. And part of this is that it's unmasking the obstructive. Part of it is, could there be from the device some increased upper airway closure that's resulting from the phrenic nerve stimulation. And so those things we kind of have to bear out a little bit more. But those are things that we need to talk to the patient about. But overall, with the device, there's about a 60% reduction in AHI, and this is mainly through the reduction in the central apneas. And patients have improved daytime sleepiness. In general, anecdotally, I would say they tolerate the therapy, they like the therapy, and things like that. But we do have probably more residual obstruction than maybe what we were prepared for with patients who get this therapy for their central apnea. Okay, that's all I have. I think we can see some things here in the chat.
I'll help you, Margaret. Thank you so much, Dr. Khan. This was a wonderful and a very informative talk. And I would like to invite everyone to ask their questions. We do have a few questions in the chat room. I also have a quick question. So you showed the pivotal trial where they did not include any opiate-induced central apneas. But is there any difference in the outcome based on the etiology of this central apnea, opiate-induced versus Cheyne-Stokes? And, if there isn't much adverse effect, like we talked briefly before, and, patient tolerated well, there's reduction in central apnea index. Is this something every sleep program should build into their program, given the difficulty in treating sleep apnea, central sleep apnea?
Yeah, so those are great questions. So I would say in terms of the opiate-induced, I'm not aware that there's anything published about opiate-induced apnea. And our institution, I don't think, we may have one that's just been implanted, but we don't have any outcomes on anyone with opiate-induced. It is something in our institution we've discussed doing in somebody who has not tolerated PAP therapy, especially if they have severe central apnea, if their opiate management is stable, it's not fluctuating, and if they have a history of addiction that they've been free for at least a year, that we would consider implanting them. So it's something we've discussed. We don't really have, like I said, I think we have one that was just implanted, so we don't have any outcome data. And as far as I know, there isn't anything published that I'm aware of.
All right, thank you. The first question I have is from one of our fellows, Dr. Musrin. Is it feasible in children with congenital central hypoventilation syndrome?
I don't think it's FDA approved for that. I believe it's just in adults. And I'm not aware if they're doing something similar in children, but at this point, I believe it's only adults that's FDA approved, I think.
The other question that she has is the device will be stimulating the phrenic nerve on one side, right? Does this mean the other hemidiaphragm does not move?
So when it stimulates the hemidiaphragm, they both engage. I don't know if it's completely known why that happens, but they do both engage with stimulation, even though it's just the one half that's stimulated.
The other question I have is how many new patients are you implanting on average per month?
So I don't even know that they're being implanted every month. I mean, we have about 25 patients in our program altogether, and they've been implanting since 2018. So I joined this program 2 years ago. There were 2 prior sleep physicians. So Dr. Rami Kayat, who's actually part of the pivotal trial and has done a lot of work with heart failure and sleep disordered breathing, started this program, then he left. And then we had another physician, Dr. Rosenthal, and she left, and then I took over 2 years ago. So, but I believe altogether we have 25. So we're not even implanting a patient every month. I mean, the majority of patients we see are obstructive. So the type of patient that's even a candidate for this is limited. And so we have 25 altogether over the last few years. I would say in the past couple years, we're maybe implanting a little more just because there's more awareness and more referrals and that type of thing. But we don't even have an implant every month. You know.
And are these the patients who mostly cannot tolerate BiPAP ST or not candidate for ASV, or they just go right? What are the kinds?
So it probably depends where they come from. We typically in our institution at least would like them to at least trial PAP. So most of them have at least trialed PAP therapy. We have a few that are just like, I'm not going to use PAP therapy. I don't want to use PAP therapy, and that's it. But the majority of them, we try to encourage them to at least trial PAP therapy before the stimulator.
The other question again is, how is the efficacy compared to BiPAP ST and ASV?
So I don't know that that study has been done comparing outcomes between patients with bilevel with backup rates and phrenic nerve stimulation. So I don't think there's any direct comparison. I will say for the central, again, anecdotally for the central apnea, I feel like our experience is very similar to the pivotal trial. The central apnea is improved, and we're actually in the middle of analyzing our institutional data and hopefully submitting that. I think the thing is that it doesn't treat obstructive, whereas PAP therapy is going to treat both. And so that's definitely obviously a benefit of PAP therapy over the phrenic nerve stimulator.
Great, thank you. Next question we have is from Dr. Andre Zinter. Andre, do you want to unmute yourself and question?
You. Hi, very, very nice talk. Thanks for giving us an overview of the process. And just curious, when you collaborate with your cardiology colleagues, they're the ones who are doing the implantation.
Yes.
And so do you do patient selection up front with them? Are you involved in patient selection process? Or how do you tell us a little bit about your collaboration with the cardiology folks?
Yeah, so they want the go ahead from sleep medicine to implant. So they don't make the decision about implant. So they will, ideally we see them in the clinic and go over their studies and look at everything with them and discuss it with the patient. There are some that come from our group. And so so if it's a physician within our group or an APP within our group, I'll just talk to them about the patient, review the sleep study. If it's within a year and it looks appropriate, then I'll say, yeah, they're okay for implant. I don't have to see them. But if they're outside the institution, then in general, I try to see them, have a recent sleep study, go over everything with the patient. And then I'll say, yeah, this patient seems appropriate for implant, and then send them back to cardiology to be implanted. So cardiology wants us to be okay with implant before they implant.
And you do all the follow-up care for them after they.
Yeah. So what happens in our institution? So the way this started was, so because there was some flux of sleep physicians, there's a cardiology nurse practitioner who's the head of their device clinics, and so she kind of took this on for them in terms of activating the patients. So she does the activation and the programming, and then they come into a combined clinic with myself and her, where we see the patient together. We see how the patient is doing. We look at the programming data together, and then I'll order the sleep studies and read the sleep studies, and we kind of co-manage the patients together.
Okay, gotcha. And how far out from the activation do you usually order the sleep study on average?
So typically they'll have, 3 or 4 appointments. So probably like about 3 months or so.
Okay, so those are joint appointments with cardiology.
So the activation and those initial programming appointments are typically with the cardiology nurse practitioner in her device clinic. And then when she feels they're ready, like she's optimized them as much as she can, then we see them together in the joint clinic, go over the programming data, and then we'll do this.
So there's a fair amount of follow-up that's being done by the cardiology team, not.
Yes. The initial follow-up is through cardiology. Yeah.
Got it. Thank you.
Thank you.
And I do have to say, just as a follow-up to that, in a lot of institutions, I think because this isn't well known, or there's not a lot of experience, the manufacturer has representatives that are going and doing these appointments. So in our institution, the fact that we're taking care of it independent of them is, I guess, the minority, just because it's a new therapy and that type of thing. So you might find it in several institutions, the company reps actually come in and do a lot of the programming.
Perfect. Thank you. Next, we have Dr. Karyagi. Ask on your own. He says, fantastic discussion, Meena. Thank you for sharing your experience. And then his question is, do we have any data on cardiovascular health outcomes, mortality with this therapy, perhaps from registries, thinking about our experience with treating CSR with ASV?
Yeah, so far the outcomes really are based on quality of life. So sleepiness and subjective satisfaction. I don't believe there's anything published about morbidity or health outcomes, hospitalizations, readmissions, those kinds of things.
Okay. Next question we have is from Dr. Jyoti Lenka. Can you shed light on outcomes to look for assessing efficacy, central apnea index versus symptoms versus long-term cardiovascular outcomes.
Yeah, so in terms of, the central apnea index, it seems like that does, according to the data from the pivotal trial and some of the meta-analyses, and then just like I said, anecdotally in our institution, the central apnea index does improve with this significantly, and patients significantly do feel symptomatic improvement and they tolerate the therapy. In terms of long-term cardiovascular outcomes, that's not known. I don't believe anything has been published, and I'm not aware if they're going to be doing trials. Now, there is something called the REST trial, which is like a registry of clinically implanted patients. And I think some of the goals of that trial will be to address some of these cardiovascular questions, but nothing has been published yet.
Next we have is from Dr. Parvati Singh. Question is, do the devices need to be reprogrammed every time they travel to a different time zone or for daylight saving?
It does, yeah. So daylight savings occurs, or they travel on a vacation, there has to be some changing in the programming times, yes.
Thank you. The last question that I see here is from one of our fellows, Dr. Zachary Adiriam. What does the side effect profile look like?
So in general, most patients tolerate it, but there can be patients who don't tolerate the stimulation that's needed to treat their apnea. And so they may have to start on the low range and have some time on ineffective milliamplitudes before they can get to the effective strength to capture their breath rate, because they don't tolerate starting at a higher range. So there is some of that intolerance issue that can occur. But in general, infection rate is extremely low. Complications are low. We've only had to have, I think we have 2 explants. One was because they had a heart transplant and they didn't have central sleep apnea anymore, so they didn't need the device. And the other was intolerance. And then there were a couple where the lead had to be adjusted. But in general, complications with this device and side effects are pretty low.
Great, thank you. And next, it says, thank you, nice overview.
Thank you.
Does anyone have any other questions? Please feel free to unmute yourself, or you can put the question in the chat room. I don't see any. Well, thank you so much, Dr. Khan. This was wonderful. And thank you everyone for joining us. We'll see you next week. Thank you. Have a good day.
Sounds great. Thank you for having me again.